I'm in San Antonio for the STS 2024, and I'll be discussing both the Chamberlain and the Clark paper. These are two awards given to the top abstracts at STS. The Clark paper, which was discussed by Dr. Mehta, looked at patients undergoing aortic valve replacement in the STS Adult Cardiac Surgery database. Population-based studies are so important in order to inform the heart team on how to treat patients with specific diseases. What we're talking about here is patients with aortic stenosis. Should they be getting surgical aortic valve replacement, or should they be getting transcatheter aortic valve implantation?
Overall, surgical volume is down over the last 12 years or so, and that's especially true for patients that are younger than 80 years old. The relative proportion of patients who now have a bicuspid aortic valve is almost half of surgical cases. We also found that outcomes for surgery for these patients are really excellent. So it's about a 1% risk of dying from open heart surgery. So that's a pretty important finding. We use the STS risk model to calculate what a predicted risk would be for these patients. And even though we have calculated this expected risk and it's low, what we're observing is that outcomes are even better than that. So what we saw in the study is more use of things like aortic root enlargement and larger valves being implanted. And I suspect this is surgeons nationwide being thoughtful about needing to set up patients for the future.
The benefits of aortic root enlargements are really important. If the valve is larger, we'll get better hemodynamics, better forward flow. These should last the patient for a decade to 2 decades. In addition, the larger aortic valve provides a platform for future transcatheter aortic valve implantation, so the patients do not need to get repeat open heart surgery if their surgical valve fails.
And finally, we found that there's a volume outcome relationship for hospitals. Hospitals that are doing greater than 100 cases per year, like Northwestern Medicine, have really better than expected outcomes.
So using this data, we can go to the patient with shared decision-making to help them make the right decision about treatment for their diseased aortic valve.